Hello everyone, my name is Aarti and you're watching Digital Health News CIO podcast where we talk to the people driving real change in healthcare. Today we are speaking with Mr. Bhoopendra Solanki, CIO at Sakra World Hospital to understand how technology is being used not just to digitalize the care but to make it more accessible, responsive and patient friendly. In a setup like Sakra, where digital platforms touch everything from appointments to post discharge care, we are going to explore what it really takes to improve patient access, from rolling out AI enabled EMRs and smart OPDs to building a patient app that actually gets used. Mr. Bhoopendra Solanki and his team are working to close the access gap in a meaningful way. We will talk through this vision, the behind the scenes coordination, the tech choices, and what it takes to make these systems work for both patients and clinicians. Thank you so much, sir, for joining us today. And today we are going to talk about how Sakra is addressing the patient access bottlenecks through digital technologies. Thank you so much, sir, for joining us today. Before we get into the
Thank you.
topic, I would first like to know about your IT leadership, your journey into IT leadership, as well as your journey into the healthcare systems.
Hello everyone, and thank you, Aarti, to help me to put my thoughts on this world-renowned platform where I can share my thought processes, experiences, and how we are going to do achieve digitalization in healthcare. Yes, I started my journey 2 decades away in the healthcare industry, and I worked in various organizations like Escort Heart Institute. Now it's a part of Fortis, Medanta Medicity at Gurgaon, and then Kokla and Dhirubhai Ambani, Mumbai. Now I'm serving in Sakra World Hospital. So this is my this healthcare journey. In Sakra, yes, we are doing many things, and on the concept of self-help. Self-help means we are providing the things in patient hand wherever it is possible without compromising the clinical care. Towards this journey, last year we changed our main backbone HIS. So HIS we changed from legacy to new age HIS, where the user demand, patient demand, and technology demand can be taken care. So that we did last year, where so many automation, so many latest technology inputs, notifications, that those things are including in that package. So that we did last year, and still we are doing the things one by one towards the patient and our internal paramedical, clinical, nurses, all departments.
Let's move on to the patient access part of it. From a leadership lens, from your lens, what does patient access mean in the context of digitally driven healthcare ecosystem like Sakra World Hospitals? And how do you define and measure access bottlenecks in today's sort of hybrid environment where there is also a physical touch point and a digital touch point?
Correct. As we all are aware, technology can't replace the clinical care, but technology can support up to greatest level in the clinical care. I'll share one example here, where during the COVID, one of the patient raised his voice I have paid full amount, and but consultant not spend much time and even not touch single time to assess my clinical condition. So we and during that COVID time we were working on the digitalization part. Then we realized wherever it is possible we will utilize technology, wherever it is possible to take care of the patient in physical aspect, we have to take care in that way. So that was the incident where we come to know technology can help in the cutting edge taking the decisions, and things where we can provide in the hand of patient. But wherever it is required empathy, sympathy to understand the patient pain, and then clinical care where a physical in person presence is required. We discuss with the our clinicians, nurses, paramedical staff, and along with our management. Management also very much part of all those discussions. Then we'll get the immediately help from them wherever we require to, like top down approach to push the enablement, or wherever budget is required, so they are helping on that as well. So all three stakeholder, we can say, one is management, second is our clinical clinicians, and third is IT. So all three are working very synchronized way to achieve the Sakra digital journey.
Sakra's digital transformation appears integrated across front end and the back end. What was the vision that guided your investment in platforms like AI-enabled EMR or the HIS, as you mentioned, mobile apps and virtual care? And how did you align the leadership, the clinical teams, and IT team to make it work in a synchronized manner? Could you please take us through that journey?
The HIS hospital information system is the backbone of the patient journey during their stay at the hospital and later as well. Majority of the HIS are legacy HIS, but and then those are running like since 30 year, 20 year, or more than 30 year. But few new and some existing HIS players are bringing the new age HIS with the AI capability, speech to text, auto navigation for the next step, auto escalations like a predefined time. It is not addressed, then it will go to their HOD or manager. Notifications various now. WhatsApp is the main mode of the notifications. Doctor level EMR customization. Earlier it was like one EMR for all, but now it is reached to doctor level, mobile app for doctors and patient. So all those things are helping in continuation our digital journey. Like last year we replace our new age HIS, where we taken close input from the management, from the technician, clinical staff, and non-clinical staff as well, because HIS being used by the clinical, non-clinical both. So various level in this HIS have a automation itself. Like I'll give one example. In a laboratory there is a biochemistry lab. So biochemistry lab, mostly results are objective, means values is coming, hemoglobin like 10, 20, something like that. Automation is there. Once we get the result from the instrument, if it is lying within a normal reference range, then system next, as a next step, take the decision. It is a this value coming under the normal value, then a report, we can release the report. So system itself releasing the report to the patient. There is no manual intervention in between, either by the technician or doctor. So immediately once machine is releasing the result, it is triggered to the patient in various channel, like we enabled 4 channel: WhatsApp, mobile app, patient portal, and email. So WhatsApp and email we are sending once all the reports are ready, that belongs to that particular bill.
You briefly touched upon the Sakra Patient App. You have a doctor app, also the patient app. Now, beyond scheduling and reports, it's also emerging as a digital command center for the patient health. What strategic decisions helped you scale its adoption and ensure that there is a utility across different demographics? Because I believe Sakra has a wide range of patients coming in who are from different demographics. So, how do you ensure that the app is accessible to everyone and everybody find some use cases in that app?
Very true. You said like beyond report and bill, it should be something else, so that patient can feel the difference, feel the experience, wow experience, and it will help to their clinical journey as well. When we are planning to bring the mobile app in 2019, and I sat with the management at that time. They said this appointment and appointment booking and reports, these are common, every hospital having. What new can do? Then I told them, sir, we'll start with payment, without payment. We will give the registration in patient hand, and if new patient are there, if existing, then no need to do the registration again, but if it is new, then registration we will give them. And only thing NABS says, we require a document which prove, yeah, credential which they filled for registration is correct, it's true. So that document we will take, and we put the AI to verify document versus the information filled by the patient. So that is unique feature which Sakra enabled. Then we come to know, like, with payment, without payment, what will be difference? If we are taking collecting payment at the time of booking, then patient should not stand in the queue. Otherwise, there is a no meaning to do the payment before and after. So for that purpose, we enabled the check-in option within a mobile app with geofencing. If patient inside the Sakra building, then only that geofencing button pop up in the mobile and they can click and do the check-in. After check-in, invoice get generated automatically. HIS trigger the this invoice generation and send to the patient. And patient name start reflecting in the doctor QMS. So no manual intervention till here. Doctor can see all their patient inside their screen on the computer, and they are calling as per their sequence and doing the EMR. Once EMR done, then patient can go, or even immediately those in, because we are using EMR giving that flexibility and helping in the patient experience. Like doctor prescribed dolo or some medicine, that medicine information on real time going to pharmacy, and pharmacy people calling that patient, sir, your medicines are ready, please come on the pharmacy and take collect your medicines. So patient is very happy, they are saving their time and getting full guidance to complete their journey in the Sakra. Similar way, like prescribe some investigation, so it is going to the investigation department, they are calling the patient. So we are stopping leakage, we are increasing the patient experience. All those things are there. Video consultation we enabled within an app. All type of reports are there, all type of bills, not only OP, IP bill also there. If your journey is ended and means last day of your discharge or relieving from the hospital, your bill, your all the report during the stay at hospital will push to the mobile app and patient portal, as well as other two channel. One more unique feature we enabled, like patient going to other hospital as well, and then coming to Sakra, so they have a document from other hospital, so other hospital document also can they upload, say, the to the same app. And whenever they are coming to the Sakra, and doctor can see and take the right decision because full history is there. And they can capture, we have enabled one more feature for the patient vitals. Like today I'm feeling cough, I can put into the app, like moderate, light, which kind of cough, or dry cough. When you are coming to Sakra, showing to the doctor or consulting with the doctor, doctor can see those history. Otherwise you will scratch your head in front of doctor when doctor asks when you coughed last time, because you can't remember. So but your app, our app can tell, they can record their allergies, so doctor can see if they have any food allergy or medicine allergy, in when during the consultation or during the hospitalization, both. They can view their discharge summary if they are IP patient, and order medicine, book radiology laboratory test, that we decided, because in few tests or few investigations, some doctor consult is required, doctor advice is required, so we not expose those test or investigation towards the patient. But wherever it is not required any consultation, any guidance from the consultant, then those test and investigation we enable in the app. Book home healthcare services, that we established in 2019. So during the COVID, we served lot many patients in the surroundings. So this way, many unique feature we brought in our app, which helping the patient. Now we crossed, I think, 45,000 a mobile app user last month.
That's actually fantastic. I mean, that number shows that there is a patient experience and there is a usability that patients are finding in the patient app. Now, you have briefly already touched upon the smart OPD and IPD automation, and how the patient app is also improving the patient experience within the Sakra boundaries. How did you balance the operational efficiency with the patient experience in these high traffic zones?
Uh, Very interesting question. Yes, because we are surrounding by the tech community, and those are very skilled in IT and as well as the processes. And many times they given the input as well about the app functionality and other things, which we taken seriously and we enabled or we rectified if some technical glitch is there. So we are always open to accept the wherever flaw is there, wherever improvement possibility is there, so we are doing. One example, like I'll give in the IPD journey. So we are almost 100% EMR enabled in IPD. There is no paper in IPD except consent paper, because NABH doesn't allow till now for the e-consent. Once they allow e-consent based on OTP or thumb impression, then we can start it. Otherwise, till that time, we have to keep the consent form on paper. But that paper also getting printed through the system along with all the detail. Only signature we are taking from the patient and keeping in one file. So once doctor prescribe in the IPD, that prescription goes immediately to pharmacy. There is no involvement of the nurse. Earlier, or in manual way, wherever EMR is not being used, it is going to nurse. Nurse is deciding those medicines, indenting, going down, or wherever pharmacies they are collecting and keeping. Now whenever doctor prescribing, immediately hitting to the pharmacy preparing the medicine, dispatching, because they have a GDA or pneumatic chute. Also there are automation in healthcare, we call pneumatic chute. That also they can push the medicine to respective ward, and then nurse is starting their treatment. So nurse is focusing more on clinical care instead of all those administrative tasks.
You have an AI based EMR now, and it also has a voice enabled CPOE. And clinical decision support is a cutting edge move that you have done at Sakra. How do you see this changing the physician patient interaction dynamic, and how does it tie back to your access strategy?
In this segment, it's a mixed this feedback, we can say. Few patient like raise their voice. Doctor is looking to the screen, not focused on our conversation and all. Few patient, they mention, yes, everything was perfect, and doctor given us electronic prescription, and it is reflecting in our app also. We are very much satisfied, because earlier writing on paper and this computerized writing, we also can understand what medicine they have written. Earlier only pharmacist can understand that writing. So mix feedback we got. If patient visited earlier, then we are showing in one side previous prescription. He can understand immediately, okay, this was the previous history. If he click that previous prescription, it will come in draft mode. Then draft mode, he no need to write everything, patient detail and patient history, all those things. He can modify current observation, current advice, so reducing time, and then save it, or wherever descriptive things he want to write, so there is no need to type. There is a mic icon on each that particular field. They can click and start speaking. It is converting to the text with almost 99% accuracy. Also, to take the right decision, we or a clinical decision support system, we enabled sims. So sims is giving them the alternate medicine detail, or if drug to drug interaction is there, it's a prompting and advising them. Earlier what happened in if they have any doubt on the medicine, or they want to see the component or ingredient of the medicine, then they have to go either Google or superior, or they are asking to the superior, or some who's the subject matter expert. But now system itself, same screen, it is showing these are the things, these are the ingredient, you can check. So all those things enabling our consultant and increasing the patient satisfaction both way.
In all this automation and all this digital transformation, I think interoperability becomes a foundational point here. What were the key enablers and roadblocks that you encounter while unifying these disparate systems under a single patient identity?
It's one of the government initiated initiative where they want to keep unique identity, just like a Aadhaar card for all the patient across country. Either they are going for hospital A, B, C, D, but same ID will work in each hospital. Maybe hospital will have a one more UHID, which is going to tag with the main UHID. Whatever till now from the era we are giving to the patient, like we always give patient report, patient prescription, patient discharge summary. All these government also saying, please enable or expose in the soft copy format towards the common platform. All those things will work once you have electronic data, means EMR. Now hospitals working towards to adopt the EMR. People are changing because it's a cultural change. Earlier, everybody is writing pen and paper, and they are comfortable, correct? Because they are doing since long. All of a sudden, we are saying you go to the computerized EMR. Then few are very happy, few are neutral, few are disappointed on this because they say, shall I focus on the computer or shall I focus on the patient? So that cultural change required in each organization. Once cultural change is done, then we'll have 100% EMR. 100% EMR means electronic data can be visible, can be sent within a click.
I think you very well mentioned that. I mean, whenever we have a unified, centralized mechanism for storing of patient data of such a vast amount, cybersecurity definitely becomes a major point of concern here, especially in an environment where healthcare across the globe since last year has seen massive infiltration and massive cyber attacks. So that's actually a very valid point that you mentioned. Let's move on to the virtual consultation part. uh, in Sakra, the virtual consultation model has matured beyond teleconsults and it has gone into the post acute and home based care. How are you leveraging this to extend care access geographically and across different patient profiles?
Yes, during COVID, it's that virtual consultation takes different role. Means in person to every hospital, even patient mindset also converted to the virtual consultation. Few hospital already ready with the virtual consultation mechanism. Few hospital during the COVID they made ready themselves and they started this journey. Coming back to the Sakra, 2019 we started this virtual consultation with the complete detail end to end. What happened during COVID? Almost 50% consultation happening either virtual or virtual versus physical in person consult. But post COVID, slowly, again, patient mindset is we will discuss in person with the doctor. So now, if you say virtual consultation, this count or percentage is very less. But Sakra is working in different way. Like post surgery, we are offering virtual consultation. Home care, we are offering virtual consultation. We specifically enable on our app and website second consultation or second thought on your decision making, which is where we'll not consult first time, we'll consult second time only. Means wherever patient taken the consultation first with hospital ABCD and then they are still in dilemma, they can talk to our doctors. Telemedicine going to definitely help, that we are working as making the centralized command center. Even IoT enabled devices also we done the POC, where patient is at home or step down ICU, we can arrange at their home, no need to bring the patient into the hospital. Or chronic disease patient we can manage from their home. So those things we are working, some level we already enabled, few things are pending and expecting next 6 months we will going to enable.
Well, all the best for that. Let's move
Thank
on to
you.
the infrastructure part of it. For a digital heavy operation, digital heavy or digital focused operations that you have at Sakra, infrastructure actually becomes a main standpoint. How has the Nutanix HCI platform improved responsiveness, uptime, and readiness for digital growth? And is cloud native infrastructure becoming a core enabler for the patient access in your view?
Now the OEMs like Dell, Nutanix, IBM, Lenovo, many other OEMs also they are in IT infrastructure part. They also offering same architecture infrastructure for on-prem. Being a healthcare, two majority or two major check we have to always check: patient data privacy and the data availability. Because if something goes wrong, then we will lose life. Somewhere else, if something goes wrong, they will lose money, I think. But in healthcare, we are going to lose life. So data availability is the major concern in healthcare industry. Considering two factor, almost all the hospital keep data critical applications in house data center. We also keeping all the critical application on prem data center, or we can say private cloud. So from this we are serving our clinic, one more hospital. That way other hospitals also doing. But earlier, if you talk about like 10 year from now, legacy hardware is there. Means if you buying one application, you have to buy one more server. Now once this we taken, I think in 2018 in Mumbai, I taken first time this Nutanix HCI. That time I was not much aware about the Nutanix, but I take the that challenge or that risk. Okay, let's see, let's explore. Literally, I worked there post implementation 1.5 year. We never log a call in the Nutanix. Same way, when I moved to Sakra and we refresh our traditional hardware with the Nutanix SCI platform, and there is no much call. Once or twice we approach the Nutanix to rectify the issue. Otherwise, no. One thing. Second, it is very much flexible, scalable, and availability also high, because three physical node combined minimum size. You can have more nodes also. So three physical node combined in a one cluster. If one goes down, another two will take care. So public or patient or doctor can't feel any hiccup or unavailability of the application. But healthcare workload is almost static, 10-5% here and there. Then private cloud is better because privacy security in your hand, and data availability, application availability in your hand. And mostly a 90% user are your in-house user. So if anything goes wrong with the ISP, internet, anything, still it will run for your customer, for your patient and users.
All this digital transformation and the one thing that management or the admin department from the hospital side always want to see is what is the ROI on this investment on this technology. Now we see some measurable improvements in throughput, patient satisfaction, or clinician efficiency. But when you have to put it on paper, when you have to show the management like what has been the ROI on this investment, what are the metrics that validated your approach?
EMR or electronic mode of the process. First, it's reduce the paper uses. We asked our this stationery department to please keep this count. Means earlier what was there, and after implementation of 1 or 2 months, what was the expense on the stationery. You won't believe, 6.7 lakh per month we are saving. Means we reduced our stationery by 6.7 lakh per month. So it's a quantitative measurable. Second quantitative measurable will come because now we are putting BI tool on top of it, and we'll start sending the preventive care messages to the patient, and then that their footfall going to increase, and that portion will be again a quantitative measurable, which we'll come to know I think after 4 or 5 months. Third is patient information is now handy for the clinician, for the nurses, even patient him herself, to take the prompt decision. This much level of information handy to them, taking the right decision, prompt decision for the better clinical care.
So, sir, like you mentioned, you have multiple platforms that are working to provide data across your clinicians, doctors, nurses, as well as your patients and the administrative staff. So, with multiple platforms that are working in parallel, how do you ensure a seamless and secure patient experience across the care continuum from registration to discharge and beyond?
In this new age HIS, the registration, from registration to till discharge, everything within this application. Recently, beginning of this month, we enable discharge process visibility towards the patient or attender. What happened in each hospital, I have a experience from the 3-4 hospital where we felt discharge is the biggest pain. What happened, once they say like go home, then patient and attender both want to go from the hospital immediately. Correct. But the discharge process, either cash takes time, means cash patient, but insurance patient take much time as compared to cash patient. That is the biggest pain area or biggest challenge in the healthcare industry. For that, one way we are working to reduce the TAT. Any patient advised by the doctor, okay, you can go home. If there is no medicine for that particular patient, automatically pharmacy clearance done. System itself done the auto clearance. No need to manual. Earlier it was happening manually. Means one person is doing all those things. Either any medicine is pending or not pending. But in this solution, we made it automated. So that's saving time. Once patient trigger in the HIS like discharge initiated, patient receive the SMS, your discharge initiated, and this is the link you can monitor or you can view the activities. In that, discharge initiations till nursing discharge, pharmacy clearance, billing bill preparation, TPA clearance, billing final bill, payment collected, and then nurse explain the complete discharge summary. All those are coming in a timeline and patient can see. And even any of the activity getting cancelled, reverted, that also they can see. Earlier they were approaching every time nurse, or sometime if they fed up to doctor also they were calling, why 3 hour happened, no one taken the pain to relieve me from here, we want to go home. Since this month we are not receiving any complaint. They are very much happy because now they have a visibility. Okay, doctor initiated this time, and nurse initiated this time, nurse completed this time. So that enablement is the a game changer for this discharge process pain area. So that we done recently. So same way we are plugging slowly all those things into our digital gamut.
From this conversation, what I have understood is that Sakra, you are a very much digital first, organization, or you have a digital first culture. But in majority of the hospitals in India today, technology adoption becomes, a sort of a major pain point. Whereas to you have to get a clinical buy-in, you have to ensure the tech adoption, you have to convince the leadership, okay, this is the technology that we want to deploy in the hospital, and drive continuous improvement. What would you suggest? What is the approach to get a clinical buy-in to ensure that there is a tech adoption and drive a continuous improvement?
Yes, very true. In this, because one way is other hospital is doing, we have to do. But in this hospital, it's a FDI hospital, and two Japanese companies are driving it, Toyota Shusho and Sicom Healthcare. So those are not looking like left and right. They always see what we are going to do next. So the management closeness with the technology, with the operations team or clinicians team is very much available in the Sakra. So that is biggest advantage to bring our digital journey so fast, so quick towards the patient, towards the employees. And they are aware about the technology, they are aware about the use of this technology. So I'm also feeling glad because all the IT initiatives, it is not like someone doing we have to do, or it's something new came we have to do. No, first we align technology with the process on micro level, how it's going to achieve our target from manual to automated. Then we go forward, first IT doing the assessment, then along with the user department doing the assessment, second level, third level with management. Once we get the principal approval, then we ask vendor to do the POC or next step. So these are our process, thought process to work on the digital era, bring the new initiatives, bring the new enablement with the help of leadership. And wherever top down approach is there, we are able to penetrate, or we are able to increase the adherence of that technology or of that process. So that is very much required, leadership involvement into the digital era.
Well, I just have to say this, as you rightly mentioned, the top down approach has to be there whenever you are implementing new technologies. But when the top down approach works in an environment like Sakra, it also tells others, or it also tells people that how much synchronization is already established between the leadership and also between the workers or the employees, clinicians, doctors, nurses, and all the stakeholders that are involved in these decision makings. Thank you so much for this conversation. I think I learned a lot from your experiences, from your journey, and I believe all the CIOs, all the IT leaders who are going to watch this episode will also take away a lot of nuggets from this conversation. Thank you so much for joining us on Digital Health News.
Thank you, Aarti. Thank you, everyone. Thank you. Yeah.
Thank you.